Hello everyone, I am Professor Willie Chi from the University of California Davis Vascular Center. I will be sharing knowledge on lower extremity superficial vein thrombosis. I do not have any disclosure for this talk. As we are all aware of, superficial venous thrombosis primarily affects the lower extremity, and in the picture on your left describe an erythematous and indurated varicose veins, and on your right, the duplex finding of an incompressibility vein with echogenicity. Although superficial venous thrombosis affects primarily the lower extremities, but it can also affect the upper extremity as described above. Most common cause of upper extremity involvement is upper extremity intervention, such as catheter placement or pacemaker placement, and rarely thoracic tumor causing venous compression. The etiology to superficial venous thrombosis is the same as deep venous thrombosis, involving venostasis, vascular endothelial damage, and coagulation changes. Now let's review some basic epidemiology on superficial venous thrombosis. It is more common than DVT at 1 to 1,000 ratio and affects 3 to 8% of general population. The risk factors are described as listed. There is a gender difference, and it affects female more than male. Based on Steph epidemiology study, the trend demonstrated a higher prevalence in female than male. However, contrary to prior notion, superficial venous thrombosis is not a benign condition, and the MEGA study showed a higher prevalence of DVT and PE events in those who suffer from superficial venous thrombosis than controls. The post-study group from France indicated an average of 10.2% incidence of DVT, PE, and extension of superficial venous thrombosis over a 3-month period after diagnosis of superficial venous thrombosis. Moreover, the Optimus study showed a close to 30% incidence of concurrent DVT in those with superficial venous thrombosis. In this cross-sectional retrospective study from the Marshfield Clinic in Wisconsin, again confirmed the concurrent rate of DVT around 36.7%. The largest registry-based study on superficial venous thrombosis found the risk of venous thrombosis after an isolated superficial venous thrombosis event at 3.4% in the first 3 months. As for hypercoagulability and superficial venous thrombosis, more common genetic abnormalities, such as factor V Leiden and the prothrombin gene mutation, carrying an odds ratio between 2 to 3-fold increased risk, respectively. But less common conditions, such as the antithrombin 3, protein C, or protein S deficiency, demonstrated a much higher odds ratio, close to 13-fold. Various forms of treatment, from conservative to invasive management for superficial venous thrombosis, have been studied, but most include a small number of patients. The Callisto trial was a double-blinded randomized controlled trial of 3,000 patients with acute superficial venous thrombosis randomized to 2.5 milligrams per day of fondaparinux or placebo for 45 days, with a total of 77 days follow-up. Primary endpoints were death, symptomatic pulmonary embolism, symptomatic deep venous thrombosis, extension to saphenofemoral junction, or symptomatic recurrence of superficial venous thrombosis. The conclusion indicated a 7-fold decrease in primary endpoint, with no difference in bleeding or major adverse event between the two groups. Next come the Surprise trial, adopting similar study design as the Callisto trial. 506 patients were randomized in 1-to-1 ratio to receive either 2.5 milligrams per day of fondaparinux or rivaroxaban 10 milligrams per day for 45 days, and the follow-up was for another 45 days, so a total of 90 days. The Surprise trial was designed as a non-inferiority trial. It concluded there was no difference between the fondaparinux or rivaroxaban group in primary event rate, bleeding rate, or major adverse events. However, interestingly, after 45 days of treatment, the primary event rate creep up, which may suggest a need for longer period of treatment. This is one of the few meta-analyses on management strategies for superficial venous thrombosis. It came from the Michigan group. 4 surgery-based studies, primarily ligation, and 3 medical studies using anticoagulation were analyzed. These were the 3 anticoagulation-based studies. Even it's a meta-analysis, the number of patients involved were quite small. Main conclusions from this study were, number 1, high surgical complications, and 2, anticoagulation seemed to decrease deep venous thrombosis and pulmonary embolism event rate, but based on the small sample analyzed, it was not statistically significant. Referencing the Callisto trial, the number of patients received surgical intervention to remove the superficial venous thrombosis was much less in the fondaparinux group compared to the placebo group on day 47 and 77. As for compression therapy in superficial venous thrombosis, this was a prospective randomized study from Austria looking at efficacy of compression versus no compression in patients with superficial venous thrombosis. Primary endpoints were quality of life indicators, including pain and thrombus length. All patients received low molecular weight heparin at prophylactic doses, and non-steroidal anti-inflammatory medications were allowed. This was a small study of 73 patients, followed up to 21 days after acute superficial venous thrombosis. The conclusion of this trial suggested 1, no benefit of compression stockings in addition to low molecular heparin and non-steroidal anti-inflammatory on quality of life indicators, including pain scale. Number 2, there was evidence of faster thrombus regression in those who received compression stockings versus those who did not, and this finding was statistically significant. In conclusion, I hope I have conveyed the following points. Incidence of SVT is greater than DVT. There is variability in clinical presentation. Lower extremity superficial venous thrombosis is associated with high risk of concurrent deep venous thrombosis. Future risk of venous thromboembolism after isolated SVT event is not negligible, and extended medical treatment may be needed to prevent recurrence. Based on evidence, anticoagulation is appropriate for at least 45 days. Surgery may reduce pain and superficial venous thrombosis extension, but does not reduce recurrence. In the Callisto trial study, less surgery was required in the anticoagulation group. There is limited data on endovascular treatment. And lastly, compression therapy may be beneficial in thrombus reduction. Thank you.